Okay, welcome everyone to the January 8th ACMT-ASAM Opioid Response Network Addiction Toxicology Case Conference. I am Dr. Tim Wiegand, presenting with Dr. Gloria Bishevitz. This webinar is available for CME credit. The American Society of Addiction Medicine sponsors this Category 1 credit. Please complete the evaluation at the end of the webinar for CME credit. First, I want to let everyone know prior webinars, we have some facts pages embedded, and you can access these through the ACMT website, and you will also have access to this recorded webinar at the end of this session in the next 24 to 48 hours. Again, I'm Tim Wiegand, Associate Professor of Emergency Medicine at the University of Rochester Medical Center, and my co-moderator is Dr. Gloria Bishevitz, Medical Director of Strong Recovery and Professor of Clinical Psychiatry at the Department of Psychiatry, also at the University of Rochester. We have a distinguished panel of experts today. I'm very happy that Ariana Sampson-Campbell, a director and co-principal investigator of the California Bridge Program, Placerville, California, Dr. Frank Edwards, a colleague and GME Research Director, Associate Designated Institutional Official, Arnett Health Graduate Medical Education, Arnett Ogden Medical Center, Elmira, New York. Eric Hill is a Substance Use Navigator in the Emergency Department at Marshall Medical Center, Placerville, California. Dr. Nick Naka is a colleague and Assistant Professor of Emergency Medicine at the University of Rochester Medical Center. And Dr. Ross Sullivan is the Director of Medical Toxicology, Upstate University Hospital, Director, Upstate University Opioid Bridge Clinic, and Medical Director of Helio Health. None of our panelists have any conflicts of interest to disclose or speakers. And I want to describe our learning objectives today are to describe emergency department initiation of buprenorphine, including real protocols to do such, and the regulatory issues surrounding initiation of medications to treat opioid use disorder in the emergency department and hospital setting. We'll also explain the effect of COVID-19, particularly during surge times, as in now, on area treatment infrastructure, and how might this impact the emergency department and ability to support patients with addiction, and describe common resources that can be leveraged either in-house or in the community to support ED initiation of buprenorphine, for example, peer counselors, recovery coach use, visit navigators, and other resources. So let's start with case one. The pharmacy didn't deliver my prescription, and then everything fell apart. Case one involves a 27-year-old male who presents to the ED with cellulitis from IV drug use. He had relapsed with fentanyl and cocaine in April of 2020. As his pharmacy changed to delivering all medications early in the COVID-19 pandemic, and his prescription was stolen. He lived in an apartment complex, and it was simply dropped off in front of his door, apparently. 28-day supply of buprenorphine naloxone films, or 58 films, are missing. He'd gone without the buprenorphine for several days. He couldn't contact his clinic or get the pharmacy to replace it. He'd used the heroin and fentanyl for a couple of days and tried to get back onto buprenorphine, and then is just back at it. He's now in the emergency department several months later, and he's interested in getting back into treatment and restarting buprenorphine naloxone as soon as possible. So let's start with some questions. First one is, in general, what considerations are important when initiating buprenorphine for patients in the emergency department? And Dr. Naka, can you give us some considerations?
Well, nowadays it's all about the duration of time it takes for somebody to go into withdrawal when you can safely start buprenorphine. And with fentanyl, I think everybody across the country is just seeing that all the rules we had in the past have been broken, and patients are requiring washout periods that are much longer than in the past. And it's like we had problems starting people on buprenorphine before. Now we even have more problems starting people on buprenorphine from the emergency room, because we have to wait so long before they demonstrate significant signs of withdrawal, and we can start them on buprenorphine safely without putting them into precipitated withdrawal. So I think that's the main thing that's coming across nowadays. And I think a lot of, I shouldn't say a lot of places, I don't know what a lot of places, other places are doing, but I think some of the barriers to using a clinical decision unit or an ED observation period have been broken down a little bit, and we're making some headway in convincing some of our colleagues to watch these patients for a little bit longer for the sole reason of starting them on buprenorphine prior to discharging them.
Right, and you really commented on particularly the induction, the initiation of the buprenorphine. Along with the starting of the buprenorphine, there's certainly other considerations that physicians have and other providers, PAs or NPs, if they're working in the ED, and that's often whether, can I start it? I don't have an X waiver in the ED, or this patient isn't on it already. Dr. Sullivan, maybe can you comment on whether an X waiver is needed and some of the issues surrounding just general regulatory guidance in the ED or hospital?
Yeah, so sometimes these things can get a little confusing. Yes, you do need an X waiver to prescribe as an outpatient. In an emergency department, it gets a little different. You're actually able to give single doses without a waiver. It's considered treating acute withdrawal. So you don't need any specific waiver or licensing other than just being having a DEA license and working within an emergency department. And you are able to dispense buprenorphine in an emergency department and give dosing, 3 days for 72 hours. So in other words, somebody could legally come into your emergency department on a Friday, Saturday, and Sunday, and they could each time receive a dosing, and that would be completely legal. And it's something that we've done actually quite a bit at Upstate Hospital prior to COVID, was sometimes having people come back in for redosing if they need it. Now, methadone is a little bit different. Methadone, the recommendations are that you should try to gain consent from the patient to talk to their said methadone clinic. And then in doing so, you can actually then give them a dose once you have actually concluded that they are at a methadone clinic. So those are pretty much the rules and regulations about dispensing methadone or buprenorphine in an emergency department.
Yeah, and actually methadone, one can give a dose irregardless of an individual being in an opiate treatment program. I think continuing somebody at a dose that they're on at an opiate treatment program, if someone comes in and for whatever reason, a heart attack or cellulitis and says, I'm on 85 milligrams of methadone, you want to certainly confirm that before just generally giving 85. But if a patient was in withdrawal, you could, based on regulations, give 30 milligrams of methadone to treat withdrawal. I prefer often using buprenorphine because we can then prescribe it to continue after the hospital setting. But whereas methadone, you can't prescribe; they have to be linked to an opiate treatment program, and that can sometimes be a process. Although there are certain efficiencies, in particular in some areas. Ariana, do you have any other comments on guidance in the ED? Any considerations?
No, yeah, we maintain a very patient-centered approach. So for us, we would certainly continue. We worked through these guidelines because there was some confusion in the beginning, especially with continuing patients without an X-waivered hospitalist in inpatient setting. But it's been very clear that not only is it legal to continue buprenorphine inpatient or methadone inpatient as long as the patient is hospitalized, but it's also, of course, recommended, knowing the incidence of increased mortality as post-discharge if a patient is not maintained on buprenorphine or methadone during their stay.
And it makes the go ahead. I'm sorry.
Oh, I was going to say, but of course, with discharge, the regular rules apply in terms of needing an X waiver to prescribe buprenorphine. So frequently, because our emergency department providers we're the first in our hospital to get their X waivers, we will actually do a consult and provide a prescription prior to discharge for patients when needed, until everybody gets their X waiver.
Right, that's excellent. There's some EM-specific X waiver trainings, and in many institutions, it's been a priority to get faculty certified. We've had X waiver trainings for medical students here, for our residents last year. We can talk a little bit about that later, but one does not need an X waiver to start buprenorphine in the hospital to continue it. And in addition to all of the reasons you mentioned, it makes the hospital stay go much easier. You don't have the patient to expect somebody that's using heroin, fentanyl, every day, multiple times a day, just to stay normal on the outside of the hospital, to not have to do that when they come in, or be very sick and, have a complicated stay is really not appropriate. I mean, they're going to, either use or leave, and then you're not able to treat them. Dr. Edwards, do you have anything you want to add? Dr. Edwards?
You're
Yes,
muted.
there we go. Sorry. The study that we did at our place, involved in inducing folks in withdrawal on Suboxone, and then getting them hooked up with a local treatment center. And the key to the success of our program there was partnering with the local treatment center, so we could try and get them in within 3 days. And if we couldn't, we would have them come back and treat them using the 72-hour rule, and it worked very well.
And that study is published in Annals of Emergency Medicine, if I'm not correct, right?
Came out in January of 2020. Yeah.
Eric, as a counselor and navigator, do you have any other thoughts or comments regarding your experience in working with patients?
Absolutely. I think that what Dr. Edwards was saying is that is really crucial, is having that piece. Like we push to get appointments next day if we can for these people once they get started on the medication, even if we give them a prescription. If we can give them a prescription, because as you were mentioning, sometimes the lives of people who use drugs can be chaotic. So we give a prescription, and then we give them hopefully a next day appointment that they can follow up with a local clinic, and that's all on my plate. That's my job as a navigator, as a counselor, is to work with people to find out where they want to go, what they want to do. With the methadone clinic thing, with the conversation about that, I've done that many times to be able to facilitate the release of information, to be able to call the clinic and have the providers connect with each other, to be able to talk about dosage, to be able to make it so that people can continue on MAT while they're in the hospital if they need to for an extended period of time, or after they leave if they need to transfer to the area. There's a lot of stuff like that we can help with. It actually takes a lot of the weight of that type of stuff off of the hospital staff.
You bring up some great points. I think that the rapidity of follow-up is, if you can get an appointment very quickly within 1 to 2 days, it's really, really important, so that they can have that connection. Whether there's ability to prescribe longer or not, I've had better success when patients are very quickly followed. And I think the use of peers or recovery coaches or navigators and counselors to take the work of linking the patients out of the physician's hands is key, and in many areas can be improved on. And many hospitals are starting to do this, are just starting to explore those options and opportunities to bring others in to help, offload some of that help, because there's a lot of this that, the navigators, peer counselors can really take the work off the physician and other providers' very busy plates in a busy ED, in particular now. Dr. Bashevitz, do you have any comments in addition, or anything from the chat that you wanted to mention?
Yes, I did want to mention a couple of things from the chat. So one is, there are a lot of questions about fentanyl and the short half-life and everything, but we will have some slides about fentanyl coming up. That's certainly on everybody's mind nowadays. The other question was addressed to Dr. Edwards, and the question there was, is it possible to get the title or link to the study that you mentioned?
Certainly, I will try and get that displayed.
We will include that with the information from the slides as well, some resources. Just in the interest of time, I want to, we talked a little bit about the regulatory guidance, a little bit more on that in a couple of slides, but I'm wondering what the panelists have also experienced in terms of community resource impact during COVID. In my experience, I had several patients that had prescription complications because of pharmacy delivery They lived in a locked apartment, and one pharmacy changed to only delivery very quickly. Some of the deliveries were delayed. We had patients showing up that couldn't get the prescription. It was in transit, and so they couldn't get another one dispensed. Some of the social unrest also earlier in the year closed some pharmacies in Rochester, and I know in other areas. So prescriptions that were sitting at pharmacies were unable to be delivered. Many on-site resources changed to virtual, and the lack of close connection or inability to directly interact with patients while having the benefits of access and connection through telehealth and telemedicine, we lost some ability to really work with patients in a direct manner. So I'm wondering what others have experienced. Maybe Dr. Bishevitz, what else from Rochester have you seen or experienced, and do you have any other comments?
Well, the main thing that we've experienced is a lot of people are very isolated and using more, and it's difficult to get them into treatment sometimes. I think there's a lot of hope now with the vaccine, but then again, people are reluctant to take it. So I think that what we need to do is, speak with people about, hey, are you planning to get the vaccine when it becomes available? I think that's helpful because we can indicate to them that we're a resource for them to ask questions.
Yeah, those are good comments. I mean, in addition, there have been, in particular early on, reduced bed availability as some programs, in particular, if they had hospital units that were used for detox wards or inpatients, were co-opted to treat COVID patients. And I think some of that's going on right now. I don't know in California, Ariana, do you have any comments on how COVID has really impacted the infrastructure or treatments in general?
Yeah. Well, initially, like when we first started seeing some changes early in March, both Eric and I got on the phone and contacted our outpatient clinics to ensure that our patients still had access. We did initially also start writing longer prescriptions from the emergency department just to make sure the patients did not have any disruption in treatment. And we also, we reached out to our local pharmacy and made sure that the medication was available. We actually, one of our clinics stopped requiring drug testing, went to a virtual platform, but very quickly also realized that they were having some issues with, there's some patients who do better, showing up. Not everybody has the same, tech availability. We live in a remote community. Some places don't have any Wi-Fi, for example. So just really meeting the patient where they're at. So we had to be nimble and quick with how we were making sure that our patients were able to continue treatment. And then also being very welcoming in the emergency department, knowing overdoses are going up, folks were using alone. We took a big harm reduction approach, flooded our community with Narcan from the emergency department. So we sort of had a master plan on how we can address this in real time and try to stay in front of it.
Yeah. We had area resource one called Hope Dealers, which is a nonprofit that had each week set up in an area that say is greatly impacted by street level drug use and poverty, and had Narcan distribution as well as access to peer counselors and syringe pickup that with the limits on gathering early in March, they had to stop the on-site activities. And so the community distribution of Narcan was really limited, as well as some connection points. There are some great resources on treatment of addiction during COVID. The American Society of Addiction Medicine has an entire series of facts and responses related to various areas of clinical addiction medicine and how to modify one's practice or best practices during COVID, everything from drug testing to prescribing to various levels of care. And that's an excellent resource. And the American College of Medical Toxicology has a position statement on the treatment of opioid use disorder during COVID that we can also provide as a resource. So I'm wondering, Dr. Sullivan, do you have anything else that you've experienced with your practice or community?
Well, these are great questions. I think, that most of the strategies that you and others have mentioned, seem to really be, the ones that we're employing, and some are obviously ones that we're we're using. I think people like peers and using them to get in the community. We have really opened up our Narcan distribution, you know, in New York State sometimes, and, you know, we have to have our I's dotted and our T's crossed on who we train and don't train. But, you know, we've been increasing co-prescribing. We've been increasing contact points to give out Narcan. And the strategies are sometimes also things that are complex, are difficult. I mean, we're increasing the amount of medication and prescriptions we're giving people because we don't want them to have to come back. Because transportation is also an issue during all this, right? Things like Medicaid cabs don't sometimes transfer between county lines in New York State and other things. So, you know, increasing the time to appointments is important, but also increasing our contact. You know, you mentioned telemedicine, and what's interesting is that even telephone, right, telephonic is something that right now is lawful to do. And I would say of our telemedicine that we do at Helio Health, a large CNY drug treatment facility, I would say about 75% of it is actually done over the phone, because we don't want to make any people have to think they need to use internet if they don't have it. So it's been a real challenge, and I think we're all learning together.
Right. Yeah, the changes in telehealth regulation were critical. They're not uniform across all levels of treatment or resource. It depends on, you know, in terms of parity and reimbursement, but the use of the telephone itself, not just real-time audio video for interacting with patients, is critical, as many patients don't have, you know, the computers, Wi-Fi access. Dr. Edwards, in a rural setting, what have you experienced? Any particularly dramatic changes in addition to what we've already discussed?
I would say no dramatic changes here. Of course, we're a very small community and close-knit, excuse me, and fairly stable during the pandemic, fortunately.
Yeah, that's good. I think also the continuing the use of injectables, Sublocade, subcutaneous buprenorphine, and naltrexone, where people have been able to do that, and selectively bringing patients in that are really high risk, weighing risk benefit has been key. And doing things like observed doses through the platforms is, you know, in my population, I reduced drug testing quite dramatically, but found that I needed for some patients to connect and confirm that they're still taking the medication. And there are ways, even without bringing them on site, like observed dosing. There's even observed drug testing capabilities through particular companies, and doing an oral saliva test through a telehealth visit. Let's move on, keep going, keep on time. I have just this slide is the actual Code of Federal Regulations for those of you interested, that describe really the non-X-waivered prescribing or non-opiate treatment program prescribing of what's called narcotic drugs, or the opioids, to treat dependence. And then the specific regulations that I want to remind individuals of: nothing in this section shall prohibit a physician who is not specifically registered to conduct a narcotic treatment program from administering but not prescribing narcotic drugs to a person for the purpose of relieving acute withdrawal symptoms when necessary, while arrangements are being made for referral for treatment. Not more than 1 day's medications may be administered to the person or for the person's use at one time. Such emergency treatment may be carried out for not more than 3 days and may not be renewed or extended. Now, that's sometimes referred to as the 3-day rule. This section is not intended to impose any limitations on a physician or authorized hospital staff to administer or dispense narcotic drugs in a hospital to maintain or detoxify a person as an incidental adjunct to medical or surgical treatment of conditions other than addiction, or to administer or dispense narcotic drugs to persons with intractable pain in which no relief or cure is possible or none has been found after reasonable effort. So the 3-day rule does not apply when someone comes in with cellulitis, or when they come in with even dehydration and or diabetic ketoacidosis, or involved in a major trauma. That medication, whether if someone has an X waiver or not, if it's buprenorphine formulation, can be continued throughout their hospital stay. If an individual only comes to the ED or hospital or office setting and are able to dispense from the office, no other, and it's only opioid use disorder, and the buprenorphine is for the treatment of withdrawal and the use disorder, then that is where the dispensing at 1 day at a time applies. And I have to say, in most patients, there's an adjunct medical condition. There's a comorbidity that's often there. Let's go back to our case, though. This patient has reported his last use of fentanyl and cocaine only a few hours prior to coming to the ED. He reports he's used less in the past 2 to 3 days because money problems, but it's still about a bundle of heroin daily and about a 20 of cocaine. 20 is $20. Prior to the relapse, after losing the prescription, he had about 8 months sobriety with good participation in an outpatient treatment program where he had individual counseling sessions every other week and a completed group session about 6 months into the program. He had good relationships with several peer counselors working with the outpatient program, and even started volunteering for a local nonprofit that was involved in syringe collection and Narcan trainings. He also had a weekly site at an inner city where individuals could make contact with peers, among other resources, some food, clothing, contacts with peers and recovery coaches, where he volunteered and participated. And as COVID pandemic began, that site closed down, and so he also lost a key part of his recovery, which was volunteering and working with others. He really got a lot of reward from that. When COVID-19 restrictions were initially placed, the on-site activities were suspended, and he said that was really hard, not being able to see my support and participate. The patient has a fairly significant area of cellulitis and a small abscess in the right forearm. There's swelling of the arm around the cellulitic area, although there's only one site of abscess. He has stigmata of IV drug use on both hands, on both arms, but no other signs of infection. He has a fever. His heart rate's mildly elevated. He's breathing fine. Saturation's okay. Other than this abscess and cellulitis, he feels okay. No cough, no shortness of breath. He's worried about opiate withdrawal, but not there yet. He's been in the ED about 6 hours now, so it's been about a total of 10 hours from his last use. The abscess is incised and drained, and the patient has started on IV antibiotics, and his labs show mild leukocytosis. His BUN and creatinine are slightly abnormal. Potassium's a little low. Bicarbonate is a little low. Lactate's normal. Glucose is normal. The patient reports he was staying in a trap house because he lost his apartment. He was staying with someone who lost their apartment abruptly. He's vague about what happened, and he's been in this house kind of just staying on the floor and using for a few days prior to the ED visit. He reports he hasn't been eating or drinking well, just trying to hustle money, but this has got to stop. So describe your process for starting buprenorphine in this patient, including doses and any supportive or adjunctive medications. So Dr. Naka, if this gentleman was in the ED, how would you start buprenorphine?
Well, if he just used recently, I obviously there's some suggestion of doing a rapid microinduction. If you're in a pinch and you don't have a good reason for hospitalization, maybe that would be something to try, though I think there's very little evidence to support it, and I really don't know how well it truly works. So if he's got a cellulitis, well, you're probably going to end up keeping him in the hospital. He's febrile. You can make a good argument for hospitalization, and during that time frame, your two options are either a washout period or what we do quite frequently is a standard microinduction, which occurs over the course of several days, but safely gets patients onto buprenorphine, whether or not they're actively in withdrawal at the time you start it. And I usually pose this question to the patient and offer them, bring them in on the decision. Would you rather us just treat you with supportive medications like hydroxyzine and clonidine? Or would you like and do a washout period, wait till you're in significant withdrawal and then start buprenorphine, kind of a standard induction approach? Or would you rather start with a buprenorphine microinduction? The answer, I think, is a little bit easier if there's a severe active pain issue like a broken bone or some other significant, like if they have to have an abscess, it's going to require surgical drainage. In those cases, I think it's best to do the microinduction because you can use full agonists as you're doing the microinduction. But I often bring patients into the decision-making process about how to get them back on buprenorphine in circumstances like this.
Yeah, that's great. And just so everyone understand, microinduction is the starting of very small sub-milligram doses of buprenorphine while the patient may be either still using or even on an opioid. Microinductions at doses that's starting at 150 micrograms to 300 micrograms can be started on top of continuous fentanyl infusions even without precipitating withdrawal and then titrated up. I've done the modified microinduction, which is so this patient, if he was saying, I'm going to go use. I'm getting a lot of craving. I don't think I can wait. I might start them at 150 micrograms and then every couple hours increase. As long as he's not using actively and you can sneak those low doses in and titrate up, you can get to the higher dose fairly quickly over, the course of an afternoon using supportive medications, and I use clonidine and hydroxyzine. And you're right, it needs to certainly be studied, but I've done it in a number of patients and not had any challenges with the microinductions in the ED. It's really resources, and are they able to dose appropriately without big gaps in care, so you're dosing fairly frequently. And then the formulations, does the hospital have the right formulations to do the microinductions? Because we're talking sub-milligram doses, and there's only the 2 and the 8s that can be challenging. There are some ways around that, but how about Dr. Sullivan? Do you have any thoughts? What would you do for this patient?
I think Ross's internet went out, Tim.
Okay, thank you. Dr. Edwards, what would you do for this patient?
Well, in our place, we would not have the pharmaceutical or expertise, the resources or expertise to, I think, start at this point, the microinduction. So this guy sounds like a really good candidate to be admitted and wait until he goes into frank withdrawal and then start the buprenorphine at that point.
And Dr. Sampson-Campbell, you're nodding. I saw. Can you comment a little bit about your thoughts?
Yeah, I mean, we have patients like this all the time. We've actually found if we can place for pain purposes, if we can place a patch, that's been really effective. Just a small 20 microgram patch to treat pain. Realizing it's not for treatment of opioid withdrawal, but we found that that's really helpful. Early reassurance with this patient that we're going to treat them. But what I've also found really effective, whether they're staying or going home, is also letting them know that if they were staying, they don't have to immediately sign up for a program, but we can certainly treat their withdrawal and pain in the hospital or emergency department setting with buprenorphine. And then if they so choose to continue that would be great. We found that we have a great follow-up rate. At one point we had like 97% follow-up rate. And I think it was that approach. A lot of folks were really hesitant initially, especially, depending on, he's there for treatment. He's there for help, saying he wants help. But we've had patients come in for the abscess, and then we're starting to talk to them during their hospitalization about treatment, and that framing to just make it safe for the patient and let them know we're also, what I liked about Dr. Naka's, his approach is very patient-centered and reassuring the patient we're going to treat their pain. They want to make sure that they're going to be taken care of. I think that's a really important approach, but we do microdosing too. So in our microdosing, we don't have a lot of fancy forms. So it involves like a quarter. We would take a 2 milligram, tablet or strip and just use a quarter dose. And the other question that I find really important to ask our patients is, well, have you ever transferred from fentanyl to buprenorphine? And if you had, how did that go? And what went well and what didn't? And then just really, to be honest, a lot of my patients are fairly good at titrating medications. And I've really just listened to them and sometimes followed their lead, and while providing good education and reassurance that if we precipitate withdrawal, we can certainly give medication to reverse that. And I always see that hospitalization for a patient with an abscess as an opportunity to treat, because we have time, as long as we keep them there, always framing that our goal is to make sure we treat our patient for what they came in for. So make sure that, he is treated, and, for this abscess as well. And feels comfortable staying and receiving that treatment.
Yeah, those are great thoughts. I like the idea of the buprenorphine transdermal patch and bringing the patient in on the discussion. And I've had a wide range of responses, such as, I'm not going to touch buprenorphine for 3 days because the last time they started it at the detox, I was so sick and it was 72 hours later. And so really getting their story and their perspective, and then sometimes educating them. It's like, we have a special way of doing this. Let me tell you how it's done. Or, if you really want to wait, that, we'll use clonidine and hydroxyzine, and here's some other options. And treating pain that is there is really important, obviously, as well. Dr. Bishevitz, do you have anything you want to add? Anything from the chat?
I think that's a great point about asking the patient what their experience was, because many of them have done this crossover many, many times, and I've seen this happen so much. Also, withdrawal symptoms are quite often in the eye of the beholder, and some will complain about minor things you think are minor and vice versa. So one of the important things from the chat is this notion of morphine equivalence. There's a question about why should buprenorphine be, can you get into trouble prescribing buprenorphine because that leads you into higher levels of morphine equivalence? And the CDC apparently has some sort of guidance on that and frowns on prescribing morphine equivalent more than 50, the questionnaire is saying.
Yeah, well, there's a caveat related to buprenorphine, really, because it is such a high affinity opioid at low doses. At the higher doses, you lose activity. So really, the idea of morphine equivalence is not appropriate when applied to buprenorphine. And I think, from what my understanding is, the review of that is more at the state level for individual prescribers, and there's certainly advocacy looking at trying to educate people on that buprenorphine prescribing is not appropriate in terms of comparing morphine equivalents. So somebody on 24 is not at a 600 morphine equivalent dose. And I would just caution people to use morphine equivalents when looking at buprenorphine, because it's you're comparing apples to oranges, and they're both fruit, but very different properties. We got to continue to move on. Oh, go ahead.
I just want to say real fast. I see a couple of questions. I know if I got knocked off from the internet about at-home inductions, and I don't know if we mentioned that. I do almost exclusively in my bridge clinic home inductions, and I love what everyone's saying. It's really so patient-centered. Everyone's asking about, is there a protocol? How do you do it? I really just ask my patients the same thing everyone else says. You're on fentanyl? Have you taken bupe before? I would say, and even in the ED, 9 out of 10 patients, if not higher, have all had some experience with bupe in the past. And I literally, for anyone in the ER or my bridge clinic that has a current withdrawal or a current low COW scores, I give every single one of them an at-home induction. There is a sheet that you can get, I think it's from, I think maybe ASAM has it or Samsung, just like general things about at-home dosing. But literally I tell people, when you feel like you're sick enough to take buprenorphine, take a little piece of it, 1 or 2 milligrams, and continue to take more every 30 minutes as you need it. And I've had probably out of the 1,000 or so people I've done this in, maybe 1 or 2 people call me the next day and say they got themselves sick. And I think that even with fentanyl, people know their bodies. And I'm just trying to, at-home dosing does work. Especially for people who have some experience. And that's the question to ask them. Do you have experience with bupe? Have you ever taken it too soon, too late? I think a year or two ago when fentanyl was a little bit more new in the scene, there were some people who with dosing got sick, but as fentanyl has been in almost all supplies, people are having more and more experience with fentanyl and buprenorphine. And I think this makes at-home dosing a pretty safe option for a lot of people.
One caveat, I found that with fentanyl, I've had much more trouble with home inductions because people start it a little bit too high, too early, and then they end up not getting on it. So the key is holding their hand, doing a telehealth visit, doing an observed dose. So if you're going to do a home induction, which most of the inductions they do outpatient now are going to be home induction because they're not coming in, I have a set visit where I'm going to do an observed dose like 1 or 2 days later, so I can make sure they're on it and really can give them some clonidine also and really walk them through, this is how, I anticipate we'll start it with their engagement if they've done it successfully in particular. If they've not done it, with fentanyl or had a bad experience, they may need a lot of hand holding. So this is an example protocol. There are a number, as you've heard from our panelists, a number of different protocols. This is one that used a higher clinical opiate withdrawal scale in general. Now it's with fentanyl, the clinical opiate withdrawal scale is harder to use because the onset of withdrawal is, and it's altered pharmacokinetics, pharmacology, a much slower onset of a higher opiate withdrawal scale. So, but in general, if you had a short-acting opioid, usually 12 hours from last use, somebody taking oxycodone, one is able to start buprenorphine if they have enough withdrawal symptoms. In somebody significantly dependent, I would not use necessarily 12. I'd probably go 8 or 10, 12 hours after oxycodone last use if that was truly the opioid. And then start with a low dose of buprenorphine. In the past, it was 2, and then 1 hour later, and 8. If there's acute pain, we split the dosing. The analgesic effect is better if there's acute pain. Otherwise, most of the patients I'm going to have on 8/2 of the buprenorphine naloxone formulations twice a day. And then we have adjunctive medications, some clonidine, 1 to 2 of the 0.1 QID PRN, hydroxyzine, and some other adjunctives depending on the symptom. The most important thing is getting the bup started. Another example from another protocol, just rural areas, emergency departments is a grant-supported project through the U of R. The initial dose is a 2/0.5 when the patients had a clinical opioid withdrawal scale above 10, and then another 2/0.5 within 20 to 30 minutes if there's no precipitated withdrawal, and then if patients tolerating that, going up to 8/2. If there's some precipitated withdrawal with that, additional low doses of buprenorphine will be continued along with the adjunctive medications. But as we mentioned, we'll talk a little bit about fentanyl. It can become tricky, and this is Indiana Jones, and this is where he's substituting the bag of sand for this golden skull. And with fentanyl and buprenorphine, I kind of think this is a little bit like that. There are some nuances. You got to have the timing right. It's not quite as tricky as that. And here's the patient waiting, the provider's waiting. We'll talk about fentanyl and the complexity of fentanyl. Fentanyl is a really short-acting opioid. If you give it in the OR to patient once or twice, and then if they were using another short-acting opioid, and you want to start buprenorphine, you can start buprenorphine 6 to 8 hours after that last dose of fentanyl. It's very rapidly eliminated, rapidly cleared. But in heavy, prolonged use, as with patients with opioid use disorder, with many uses throughout the day, the fentanyl becomes trapped in the lipids. It's very lipid soluble, so they get a depot. So now we've got most of our patients using fentanyl. It's like they're using fentanyl, but they've also got a fentanyl patch that has the depot in the skin. This is a diagram from a paper by Kuhn from Eric Strain's lab that it involved 12 patients in a 28-day inpatient treatment, and showed that they checked the urine for fentanyl and norfentanyl and found that the mean detection time for fentanyl was 5.9 days with a standard deviation of 4.7 days. Now, this is a small group, but it shows what clinically we're all experiencing, that fentanyl hangs around a lot longer than it should in patients that use heavily compared to infrequent use. In fentanyl, infrequent or a single dose, it's all gone within 48 to 72 hours in the urine. So it hangs around a lot longer. This is that vapor. It's very lipid soluble. You have prolonged results ending it with a depot, which is why we see the precipitated withdrawal. We talked about the microinduction strategies, and again, reassure the patient that they'll feel better, and you're there to help and engage them. So let's get back to case 1. After fluids were started along with antibiotics, replacing electrolytes and thiamine, the patient is given ibuprofen, acetaminophen for mild arm discomfort, clonidine and hydroxyzine are started, and the initial plan was to wait until the clinical withdrawal scale is greater than 10, and it's been about 24 hours since last use, or if withdrawal more severe earlier, then the buprenorphine naloxone can be ordered. At 24 hours, the patient reports he feels aches and some rhinorrhea, but says, I'm not ready yet. The fentanyl has messed it all up. He's restless and has commented to nursing that he might just leave and can take oral antibiotics. He's been admitted to the hospital service with addiction toxicology, CL consultation, but still boarding in the ED. And so now my question is, how can providers support this patient to facilitate appropriate treatment for infection, initiate buprenorphine, and get stabilization of addiction at this point? I'm not talking necessarily about medications. We've talked a little bit about that. What are the other resources that you might bring to bear for somebody that sits in the hospital that you could, marshal some supports? Eric, do you have some comments? How are you working with patients, trying to, get them to stay while, the pharmacology and the medications are getting situated?
I'm glad that you asked. I've seen this type of situation a lot where it's just taking a long time. And I think that everything we're talking about when it comes to individual dosing and stuff like that is super important to know, because each person might have a different supply of drugs. each person might have a different strength of drugs. It might be heroin, it might be fentanyl, it might have some benzos mixed in. There might be all sorts of different stuff and mitigating factors to the washout period that we're talking about. So talking to those people and going and asking them, do you know about these drugs? How long is it going to take for you to come down off these ones? When are you going to start doing it? It's a very personalized thing. So I really dig that. And going with that on that vein, if you will, to of personalized care, right? Where if we're comforting them, this person hasn't eaten or drinking any food. If there's nothing indicating that they can't have oral food, if they can't intake anything, obviously like getting a counselor like me involved in the emergency department to facilitate getting that case management rolling while they're in the emergency department. So when they do get transferred, we can connect with case management on the inpatient side and go, look, these are our key components. This is what's going on. This is where they're going to follow up for Matt, really being that thing that carries along with them. And then they want to leave. Of course they want to leave. They're uncomfortable. They're in pain. They're feeling all of this, maybe some pressure, maybe some stigma, some stuff from the hospital. They might be feeling craving, all that stuff that goes along with it, and just reassuring them that there are motivations, right? In the slide before this, it talked about 8 months of sobriety, right? Being in recovery, having that social support network, and really using motivational interviewing or motivational encouragement to get these people to realize the reason you came in is this. Let's keep you on that track. We're going to keep you comfortable, and we're going to work with the doctors to make this happen for you because you can do this.
Right. And you mentioned, that 8 months prior. I think getting this patient to try and reach out to one of the peers that they work with while they're in the ED, or if you have an iPad and you can have them access a meeting if they are, interested in trying to do a remote or virtual AA or NA meeting. There's meetings all around the world. I had one patient access one in Copenhagen and was fascinated by, joining a self-help meeting. Or family via phone. I think using the resources. A lot of times when people are experiencing withdrawal, they're rough to reach out, but they may reach out to someone like a peer or that they had a connection with. The addiction consultation provider meets with him after about an hour. He's made comments about leaving. He's had little sleep overnight in the ED and is irritable. Instead of standard buprenorphine induction, the process for microinduction is reviewed. The patient agrees. Try this. He's also given a dose of diazepam and 0.2 clonidine, and now he's because he's become more restless. And this, we use buprenorphine 150 micrograms followed by 2 doses of 300, ordered 2 hours apart. That actually was a little bit further than that by the time they were ordered. He tolerates both of these. And after that, a 1 milligram dose is given. So just kind of slowly titrated up, and he starts to feel better. And then the 2 followed by 8s. And so he gets onto the 8s and that are continued throughout a 3-day stay. The patient contacts one of his prior program's peers after the first few doses of medication, and he has a call that went well. He's planning to re-engage with his prior outpatient program at discharge, and he reports that his sister will let him stay with her if he agrees to go back to the program and isn't using. At discharge, the patient is given a 6-day prescription of buprenorphine for the 8/2 twice a day. He leaves with medication from the hospital outpatient pharmacy along with oral antibiotics and hydroxyzine for 3 times a day for 7 days. His arm is improved. Blood cultures are negative. He has a follow-up appointment with the outpatient program 4 days from discharge with their provider on the morning of day 5. So we talked a little bit about the role of peers and recovery coaches in the treatment of patients with addictions, what this level of certification includes in terms of training, not so much. We've got another case, and so I want to just see if there's some final brief comments from panelists regarding maybe these questions before we move to case 2, which has a little bit different emergency department situation. Dr. Bishevitz, do you want to make a comment about peers and recovery coaches and a little about their training and certification and your experience? You're muted.
So the quick comment would be that they're great, and there are some different trainings in different areas that people could take advantage of. I talked to one patient this morning who was staying in a halfway house, and he said that he was taking peer recovery classes even in the halfway house to become a peer recovery coach. So, and he was very excited about that. So look into it in your area. I think there are little different regulations everywhere.
Yeah, the regulations vary by state. In New York, they are reimbursable, and often included in part of the program in greater numbers from what my experience is. Any other comments on peer recovery coach, Dr. Sampson?
Yeah, I was just gonna, we started a huge program because we call them substance use navigators, and they're kind of like peer recovery, and also like there's a case management part of it. So we combined those two things. And really what we found is our substance use navigators make it safe for patients to come into the emergency department, which has been a very intimidating and really stigmatizing environment for a lot of folks previously. So they're a friendly face, and no matter how much I want to engage patients, Eric is better at it than me. So I'm respectful of that. And this has become a very, it's been cited by 52 hospitals we started programs at as the biggest change maker type of position in the hospital. And now we have California supported the placement of 208 substance use navigators across the state. And what that creates is also communication. Now we get our substance use navigators to communicate, and if somebody moves or etc., care is continued. So there's a lot of reasons that this works so well to really just advocate for the patient in front of you.
That's great. I like that in particular as a network of communication. That's probably much more efficient than the offices and the other. How do you find a provider? So Eric, do you have any final brief comments on this? We're going to move on to the next case.
Final brief comment. Well, I've said a lot, so I'm not going to beat a dead horse, right? It's pretty much what I've been saying the whole time, is that meeting people where they are. It's easy for someone to meet someone where they are when we've been there, and it's not saying that someone who hasn't been there can't, but it's just that, not to like sound too street or anything, but real recognizes real. You know what I mean? Is that people can tell right away if you're full of it or if you're phoning it in. Or whatever, right? Or if you really care, and that's the thing. The certification level, we haven't found a certification that is perfect for this position yet. I like it when people are able to talk about substance use in a clinical way, but I also like it when people just have personal experience with it, be able to talk about it in a real way. So we have nurses, we have social workers, we have case managers, we have certified drug and alcohol counselors, and we have people who are interns to become certified drug and alcohol counselors, and people who are peer specialists. It goes across the board. It's just really people who want to help people who use drugs can be successful in this.
Very good. Thank you. Let's move along to a much briefer case 2, a long wait list and closed doors everywhere but the ED. 38-year-old male is interested in getting help for stimulant and opioid use, but the inpatient program he'd wanted to enter is holding admits due to a COVID-19 outbreak, and there's a 2-week wait for either telemedicine or on-site evaluation at the county treatment program in a rural part of the state. After 3 days of trying to detox at home, he presents to the ED because I didn't know what else to do. Patient is in fluid opiate withdrawal with rhinorrhea, tearing, yawns, repeatedly is vomiting and diarrhea, is extremely anxious and restless. The patient lives 45 minutes outside the city, but he heard that he might be able to get started on Suboxone in the ED. So I came up, I just couldn't take it anymore. So what are the patient's options for treatment if he presents to in the panelist system ED? I think we've already covered this. And, this is a very easy buprenorphine induction. It would be a standard, give a dose, you should feel better. So Dr. Edwards, maybe you can comment a little bit more on the challenges. What challenges are rural emergency departments, hospitals, and treatment systems face with compared to urban counterparts? What are recommendations from panelists to surmount some of these? Do you have any additional thoughts? We've covered this through much of the presentation, but any other suggestions?
Well, that was our situation was a very high rate of opioid use disorder in our little Rust Belt city, about 2 hours south of Rochester, and extremely long waiting times to get into MAT providers. So we came up with the idea of developing an outreach program with the ED being the rapid portal of entry. They come in, get treated, and get referred. And so we studied it for a year, and I think we're reasonably successful. We had about 80 patients come in, asking for it. 53 actually met criteria for getting buprenorphine. We had no cases of precipitated withdrawal. About 20 of them needed to come back for repeat doses, and the 81% of that cohort that got treated followed up, made their first follow-up, and And the 30 and 90-day follow-up rates were extremely good as well too. So we didn't have access to peer support as much as we would have liked, but clearly that's a huge component, very important. And moving forward, that's something our community would be working on.
I want to move any that is not deaths now in the United States on daily. What are the current implications, in particular in your area? Are there any more dramatic impact, bed availability, access to providers as cases and hospitalizations have surged? Any specific examples? I mean, in our area, I know that staff have become ill and there's nursing shortages in some of the treatment programs and inpatient units. There's been clusters that have limited some bed availability. But what from California, Dr. Sampson Campbell, what are you experiencing now?
So this particular case, well, we have experienced significant increased overdoses, which we actually see as an opportunity to start buprenorphine as well. So we give post-overdose buprenorphine. And the other thing that we do is we actually treat our patients very quickly. So we do not, for a really straightforward case like this, we would treat this patient in our fast track. What this would look like is Eric would meet this patient in the lobby if he's there or had already spoken with this patient. We would bring them back and very quickly administer pretty high dose buprenorphine based on their use pattern. If they're using heroin, we feel very comfortable giving a quick 8 milligram of buprenorphine, reassessing within an hour and giving at least another second dose before they leave. And we actually see this as a protective dose, because if they leave and use again, we're really trying to kind of, take up all that receptor to protect them. We see this, and even post overdose, we give 16 milligrams post overdose, and we see it as protective. These are for straightforward overdose cases. So that being said, we will treat this patient in less than an hour and a half in my emergency department, and we have preset outpatient follow-up time, so it's really simple. Eric can connect them to next day treatment, and most of my ED clinicians have X waivers and prescribe. So even if it's on a Friday before a holiday, or for example, a Wednesday before Christmas, we're able to give a prescription to last until they're able to follow up. So straightforward cases like this are our bread and butter, and we've become pretty efficient and good at treating our patients in this way. And in terms of COVID, the only thing I was going to add is I would talk to this patient very early about a long-acting injectable buprenorphine. We're in a rural setting, and our bridge clinic has more than 100 patients who are on the long-acting buprenorphine. It really works in a rural setting when transportation issues and COVID are considerations.
That's a great comment, because it doesn't just dip and end at the end of the month. They have some extra time. This patient was given a 2. I agree, this patient probably could have gotten an 8 right off the bat, but it was given a 2 and then an 8, and feeling better after the 2 and much better after the 8, and then he leaves on 16. He has outpatient clinic and a 2-week wait list where he lives. He didn't take the position because he was upset. He was trying to call around. Ultimately was placed with a local clinic and telemedicine support. We're coming near the end of the webinar. This is a picture a few years ago that I used in my slides from Dr. Sullivan in his bridge clinic. Is it featured in one of the local newspapers. I want to give kudos to Dr. Gil D'Onofrio from Yale, who had really the seminal work from emergency department initiated buprenorphine, the trial in JAMA in 2015 and subsequent work. And there's now been a number of publications regarding ED or hospital buprenorphine. And, you commented a little bit on the mechanism to start buprenorphine quickly after an overdose, or not really the mechanism. Some individuals have advocated after a big dose of naloxone, you can sneak in buprenorphine. I know that's done. Dr. Naka, I believe, did that recently here. There's a case publication on this. We're really coming to the end. So I think, unless there's final pearls on buprenorphine from the panelists, Dr. Bashevitz, any final pearls on this webinar of buprenorphine?
No, I think that we've covered a great deal of territory here. Yep.
Okay, Dr. Edwards, any final pearls?
I've cast all my pearls.
Okay, Dr. Naka?
I just comment that, I think there is probably a role for slipping in buprenorphine immediately after an overdose, but I think it requires a high degree of comfort and experience. But I'm not an advocate that become commonplace in providers that aren't facile with buprenorphine, with opioid overdose and opioid withdrawal management strategies. And then I'm an advocate for a low test dose. I think that there's very little to be lost by taking an extra hour for a test dose, and potential to be gained, because if you do have withdrawal, which I have precipitated some withdrawal because I'm not perfect in the past, I think there's, that has a long lasting psychological impact on a patient and may deter them from future buprenorphine inductions or long-term management. So again, in a proper clinical setting, of course, you can go with a high dose right off the bat, but I think that's something that really needs to be left to expert level intervention. And I think for run-of-the-mill or standard emergency providers who are starting into this, I think a test dose is an appropriate starting place.
I agree. I like this smaller intent. You can always give more getting it in. Dr. Sullivan, any quick final pearls?
Nothing other than talk to your providers about getting waivered and using a medication that is safe, has great data, yeah, just keep treating the patient the best we can. It's a great tool to have in our toolbox and learn how to use it, and probably use it more.
Not a black. Yeah, right. Dr. Sampson Campbell, any final pearls?
Yeah. Oh, and I did want to clarify, I'm a PA, just I didn't want to misrepresent myself. That being said, yeah, my last pearl is we treat opioid withdrawal as a medical emergency and stabilize just like we would other emergencies, and feel that this should be just, this is standard of care treatment and should be implemented everywhere with that in mind, including the rate of mortality. If you're not treating, this is a no-brainer. This is a standard of care.
Very good. Eric, any final comments?
I do. So we had this one case one time where this guy, he overdosed on fentanyl while he was injecting methamphetamine. This guy was very confused when he woke up. He was falling back into overdose repeatedly. He was very uncomfortable. Once we got him to stay awake, we gave him bupe immediately. Ariana talked him into taking bupe because he was feeling so crappily. Not necessarily talked him into, but offered it to him, saying it may make him feel better. He took it one time, did it safely. We gave him some fentanyl test strips that we can give out from our local harm reduction company, so he could test his methamphetamine in the future. And we gave him a bunch of Narcan, bunch of education, and we told him to be safe. So my final pearls are: help people test their drugs. If you can get test strips, help people test their drugs. Give out Narcan like crazy. Teach people how to use it, and get it so you can give it out of your emergency department, because that's been a huge thing for us, being able to just give it out of our emergency department.
You bring up the adulteration of the drug supply with fentanyl, whether it's the counterfeit oxycodone or the stimulants. Many areas have high rates of fentanyl adulteration, particularly methamphetamine and cocaine. Varies by area. But I want to thank all of our panelists. I end with typically a final thought. This is a poem from Richard Brautigan, and I want to read this. It's called "The Day They Busted the Grateful Dead." The day they busted the Grateful Dead, rain stormed against San Francisco like hot swampy scissors cutting justice into evil clothes that alligators wear. The day they busted the Grateful Dead was like a flight of winged alligators carefully measuring marble with black rubber telescopes. The day they busted the Grateful Dead turned like the wet breath of alligators blowing up balloons the size of the Hall of Justice. And this is from the Pill versus the Spring Hill mine disaster, 1968, Richard Brautigan. Thank you all for joining the next case conference. We skipped March. We have the New York Society of Addiction Medicine annual conference, the Public Policy Day on the 5th, on Friday the 5th in the afternoon, and Saturday morning the 6th. So if you're interested, check the New York Society of Addiction Medicine website. That's a fantastic conference. We have a toxicology panel at that conference. There's also the ACMT ongoing toxicology series as well that's held in Fridays throughout March, through February and March, and you can get more information about that on the ACMT website. March 5th is the next webinar. We'll be talking about pregnancy and opioid use disorder and have some guest experts, and we will end today. Thank you again for joining, and thank you panelists for attending. This is recorded and will be uploaded shortly to ASAM and the ACMT websites, and complete your CME and evaluation so we can continue to review and improve. Have a great weekend.